Dr. Demetrio J, Aguila III, and I'm the host of the Direct Care Movement podcast, where we talk about the intersection of money and medicine, two topics that typically don't go together. We often think of them as water and oil, but we're going to show you today, by diving into a lot of the questions that you have, and maybe even some of the questions that you don't realize you have, that it's okay to talk about money and medicine together. As a matter of fact, it's important for us to do that. We're going to dive into questions that you've wanted to ask, that maybe you were afraid to ask, or didn't know how to ask, or didn't know you were allowed to ask, as well as some questions that you probably didn't even realize you had until you started listening to this podcast. We're going to dig into that and a whole bunch more. And I'm really excited to have on board with us today Dave Chase. He is one of my heroes. He's one of the guys that helped inspire the genesis of my practice and continues to inspire the growth of the Free Market Medical Association chapter here in Nebraska. And so, Dave, I'm excited to have you on board today. Thank you for joining us.
Well, thanks so much for having me and the kind words.
Thank you. So, Dave, not everybody in our audience is familiar with who you are. So can you tell us a little bit about yourself and tell us a little bit about Health Rosetta?
Yeah, I'm essentially leading a social movement, a kind of recognizing that health plans, they're sort of this hidden thing at some level in healthcare that govern everything. And, certainly with recent news events, it's pretty clear that people aren't happy with the things that are happening with health plans. And ultimately, we created this organization to rebuild health plans from the ground up. It's kind of like the direct care movement. We can't do it without the direct care movement. We're not clinicians. And so one of the things we recognize is that every community, where that community is a place like Nebraska or Omaha, or a community could be an employer or a union for that matter, every community has a river of healthcare money flowing through it. And guess what the source of that river of healthcare money is? The community itself. But unfortunately, rather than that river of money working like a water cycle and creating a better and better health and keeping those dollars in that community, because what drives outcomes is not only what happens in the doctor's office or hospital, but what happens in that community. And so, unfortunately, a huge chunk of those dollars are diverted to Wall Street and their water carriers. Clinicians only get 27 cents of every dollar. We need some overhead. We don't need 73 cents of every dollar to be overhead. And so a lot of what we do is, as you build these plans up from scratch, you say, you know what, healthcare is not expensive. As I said, clinicians only get a pretty small portion. What's expensive is profiteering, administrative bloat, fraud, some inappropriate care, and some price gouging by hospitals. Well, we choose to not participate in those things. And so it makes healthcare incredibly affordable to do that. And that's where we're in such a common cause with the direct care movement, because like us, we started, 8-10 years ago. There had been some early pioneers before that. Likewise, in the direct care movement, there were some early pioneers, the Keith Smiths, the Garrison Blisses of the world. I actually wrote the seminal paper on direct primary care. There were these early people, but now kind of in parallel, these two movements have grown, and it's pretty incredible. We can get into what the impact has been. At the end of the day, it's the human impact that matters.
So tell us a little bit more about the genesis of Health Rosetta.
Well, the genesis really was a personal situation where I saw a friend essentially ruined by the healthcare system. She got the wrong diagnosis, led the wrong treatment plan, and somebody who'd done fairly well financially, was crushed. Basically died bankrupt, leaving behind a 10-year-old daughter. And it wasn't because there were bad doctors or bad nurses; it was just a bad system. And so it put me on this quest, and I kind of went from, I call myself like Indiana Jones, the archaeologist, sort of searching for healthcare's Rosetta Stone. like somebody's had to crack this code. Like this, I'd been a part of the system from a health technology standpoint, and I realized it was a system problem. And so who's fixed this problem? And I found it. I found on the care side, I found direct primary care. On the employer side, I found Rosen Hotels. My TED Talk was about them. And you fast forward to today, they've cumulatively saved $540 million compared against other hotel companies in their area. And they have a very significant disease burden. Just to give you one data point, 56% of their pregnancies are categorized high risk. Yet they've done this incredible job. And then I was like, gosh, on the one hand, you have this dystopian reality. It's awful for the clinicians. It's awful for patients. It's awful for our country. It's awful for businesses. It's devastating public budgets. Like, it's dystopia, other than for a very small set of people who are profiting from the dysfunction. Over here, we've got utopia by comparison. They save so much money. They grew their hotel company 10 times without taking on any debt. But the best part was they said what we've now called the Health Rosetta dividend. They were the inspiration. They saved so much money. They took about 5% of it and said, we're going to invest in kids and education with their own workforce to begin with. All the employees and the employees' kids get college education fully paid for. Like, that can be up to $250,000. And then they did the same in the community. And so I went from Indiana Jones to Johnny Appleseed, like, I just got to get this word out, right? Like, this is kind of just a marketing problem on some level because it's utopia versus dystopia. And when I wrote my best-selling book that kind of launched this movement, I could only find 5 successes around the country. Now we've got thousands of successes. And when I call successes, I'm not talking about individual patients, although they're a big part of it. I'm talking companies. So it's, there's about 5 million lives directly in our community, kind of the extended community. It's like 10 to 15 million lives. So it is definitely spreading. It's not yet the norm. We got work to do. But as people like you who are fed up with the old system say enough, then community by community, healthcare gets rebuilt from the ground up. It's basically a new economy. I call it the healthcare ownership economy. It's basically people taking ownership. Like, okay, apparently the cavalry's not coming from DC to fix it. It's on us. We're going to do it. And you take ownership, and then eventually, we get into what we call community-owned health plans, where the community reclaims what I think of as health sovereignty. They've essentially let their communities unwittingly get colonized by Wall Street and their water carriers. And as I said, they say enough. And because they can control that river of money, then they can make it happen. And that's frankly the biggest obstacle. Is most people think solving healthcare in the US is like trying to solve Middle East peace or something. Like, they'd like that solved, but it kind of seems out of their control and maybe hopeless. And as long as you believe that, you're right. If you don't believe it, you're also right. And so that's really what we're doing, is just spreading that word and just doing the hard work of rebuilding the system brick by brick.
Sure. So what you're really talking about is, subsidiarity applied to healthcare.
Absolutely. Like, early in this journey, there was an ER doc who's kind of a systems thinker, and he's kind of a funny guy, a little caustic, and he's like, Case, where does health start? I'm like, Mom, Dad? He's like, you're the first tech guy who's gotten that right, And I'm like, well, it's kind of common sense. And then it fans out from there, right? And as I studied this around the US, around the world, that subsidiarity is really key in that, it's this concept of pushing things to as local as possible. Because, like, take where I live, we're in a county kind of up against the Canadian border in Washington State. Olympia, the state capital, is probably, I don't know, 150 miles away or something. Frankly, it's as distant as DC is. And when you govern those dollars at that local scale and take control of that river of healthcare money, then when you don't squander money on profiteering, price gouging, administrative bloat, and whatnot, you can do the sort of things that Rosen has done and say, hey, let's actually go put that into the things that drive, guess what? 80% of health outcomes are not the healthcare system, right? It's having pay and education and clean air and safe neighborhoods and these things, kind of common sense when you actually think about it. And that's one of the, there's a few things that we've learned that most people haven't known yet. One is we're already investing more than enough money to not only fund a world-class healthcare system, but to fund a restore funding to what drives 80% of health outcomes. And, it starts with take-home pay, right? The working and middle class, over half of households are in a 30-year-long economic depression. One definition of economic depression is 2 or more years of wage stagnation or decline. And there's only one reason that's happened. Healthcare has stolen all those dollars. It's not some 10-point conspiracy theory. It is a direct line. And so once you do that, and what we found is the right scale from a population perspective, and going back, that subsidiarity is sort of like school, water, fire, congressional district. 25 to 500,000 seems to be about the right area. And then when you don't squander that money, you're controlling those dollars, you say, oh, let's go address senior loneliness or early childhood education or food desert or whatever it is. It's your particular community's challenges. And I can practically guarantee you that my community's challenges are different than yours, and they're different than just about everybody else. And they understand that problem much better. And so it's giving them the dollars to control and, really take that ownership. That's why I call it the ownership economy.
That's awesome. So let's talk about these local communities and this subsidiarity. First question that I'm sure a lot of our listeners have is, how come I never heard of this before? I mean, you say you've got 15 million lives that are involved in this, and I mean, obviously I've heard of it, but a lot of our listeners are like, this is all new to me. This has got to be some kind of con. Convince me it's not.
Yeah. And I would probably think that too. In fact, when the things I was saying when we started, about what could be done, if somebody said that to me, I would say, okay, good luck. Come back to me in 5 years and prove you can actually do it, because we have decades of failure that suggest you can't do it. And so that's one of the reasons we get together once a year and celebrate the best best health plans in America, is so that people can see kind of birds of a feather. Oh, there's a 100-person manufacturing company like mine, or, oh, there's another company from Nebraska, or there's another city, or, whatever that common thread is. And so for the most part, why don't you know about us? Like, we're an organization that hasn't, we have yet to hire any sales, marketing, or biz dev people. I mean, you are looking at the sales, marketing, and business development team right now. And to my earlier point, we could have had the best messaging, the best sales team 5-7 years ago. It wouldn't have mattered, because people prove it. And so we just kept our heads down and said, when we get, over 1,000 successes that are in place 3, 5, 10 or more years, all the traditional fear, uncertainty, and doubt that any player that wants to protect status quo will use stops working when they can see it with their own eyes. Like Ashtabula, Ohio is a good example. It's about 45 minutes north of Cleveland. It started with a single private sector employer with 38 lives. Not exactly a huge movement, right? But it's also a medical desert, less than 30% per capita docs in that county, 8th poorest county in the state. And then when the school district, like many organizations, certainly public entities, were challenged budget-wise, and they heard about what was happening with some of these private sector employers, they said, hey, we're going to give it a try. And it was interesting. They actually put the new health plan in place July of 2020. You might remember that was kind of an interesting time, right?
Yes.
In our environment. Um, and and then May 2021 comes up. Even though it's a very challenged, kind of very stereotypical kind of Rust Belt, community, opioids, economic challenges, plant closings, like check, 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 medical desert, they would usually pass the school levies. Well, the school levy failed. Normally, that would have been a disaster. Cut teachers, programs, maybe the schools, small school district. Well, even that short amount of time, they'd already saved more money in their health plan than the entire school levy. And it caused that superintendent to basically hit a pause on his career, because like 9 months later, he's like, you know what? I got to spread this message to the other 600 school districts in Ohio and beyond, because I actually can have a bigger impact on kids in education by getting this health plan thing figured out. That's basically been stealing from, other things that drive, well-being in our community, which was pretty amazing. And then it was kind of funny. Of course, there's many other employers who hadn't done it in that community. And a lot of the private sector folks think that they're a little smarter, than the public sector, or more nimble. And they're like, oh my God, the school district did it, and then the county, and now the city's doing it. And so it's just become a new norm in that community. And remember, this is a medical desert. There was not a single DPC practice. There was a one hospital town. The 900-pound gorilla in that state was throwing its weight around. But you know what? You can solve these problems. The advisor called, went to DPC Mapper on the DPC Frontier site and saw, oh, there's a doc 45 minutes away. I'll call them up and say, I got 400 people waiting for you to be their doctor if you'll come up 2 or 3 days a week. We got this empty room in the school that can be your clinic. So took all the risk out for him. And then for a while, rather than getting price gouged at the local hospital that didn't have great outcomes on some, important areas of medicine like musculoskeletal, they didn't take away the current plan. They just said, hey, here's this new thing. In fact, this was outside of the collective bargaining agreement for the school district. They said, hey, if you, with this concierge nurse navigators helping you navigate kind of the clinical and financial, and they're not financially conflicted, they just want to get you to the best care. If you go to one of the 3 options we pick, best surgeons, best facilities, lowest complication rates, all that, always leading with quality, you'll pay $0. But would you be willing to drive an hour? I remember, when I bought my first car, this is early on when, you could buy cars online. And I had a pretty good job at Microsoft. I mean, I could afford to overpay by $500. But there was a dealer 45 minutes away. And I said to the folks like 2 minutes away, I said, like, I can't not drive 45 minutes to save $500.
Right.
Will you match it? Sure. And that surgery center, number one, quality facility, one of the best in the country. They got so much business in Ashtabula, which is not a huge place, like 100,000 people in that county. They open up a facility in their community because they had enough business there. So they're starting to chip away at that medical desert. That's the type of thing. You bring these problems that seem impossible to solve at a national or global level, you bring them down at principal subsidiarity, these problems become solvable. And that's what we're doing. And we don't worry about marketing. Word of mouth spreads. Yeah, over time, we'll probably pour a little gas on the fire, but right now there's no reason because we're growing as fast as we can. And this is an industry. If you think about this new economy today, it's already bigger than the US video game or textile industries. It's not as big as the $5 trillion industry, make no mistake, but it's already big by any rational measure and growing exponentially. And, pick your example. Facebook was tiny at one time too, right? Like any exponential, you double enough times, before too long, it becomes pretty big. Back in Ashtabula, it went from, health plans typically are kind of measured year by year. Like we just had a, turnover the new year. 80% of plans go live on January 1st. And they went from 38 lives to 535 lives to about 1,300 lives, about 3,600 lives. And they continue to grow in that area. So you can start pretty modestly. And guess what? You get in that kind of 5,000 lives. Actuarially, that's really interesting, even more interesting when it gets to 10,000. And you basically, these companies realize they're all little insurance companies, right? They're actually picking up the dollars, even if it says, Blue Cross or United or whatever on the card. It's the employer and the employees who are actually picking up the bill. Sometimes, I'll joke with people, when the whole topic of single payer comes up, like, we already have it. It's you and me. I haven't heard any Italians or Australians volunteer to pay for our bills, right? It's just a matter of how many, people grab money, out of the pie. And so it's a health plan as a health plan at some level, right? You got to have great primary care. You got to have great surgeons and, hospitals, and you need it, drug coverage. I mean, this is, at the end of the day, it's not rocket science. People want you to believe it is, but it's not, when you rebuild it brick by brick.
Sure. Now, you mentioned earlier that you need direct care in order for Health Rosetta to be successful. Can you dive into that a little more? Tell me, where does direct care fit into all this?
Yeah. Well, it starts with direct primary care. It's not a state secret. There's no well-functioning healthcare system in the world not built on proper primary care. So that's been something we've really, I wrote the seminal paper on. I've been a believer. I mean, I've advocated it more than anybody that doesn't have skin in the game. It's obvious. It's the right thing to do. So that's the first piece. And then, you think about sort of amount of spend, but also there's kind of an inverse relationship with frequency. So things like labs, very frequent, pretty low cost. You can get direct contracts. Imaging, a little less frequent, but you can get contracts with independent imaging facilities, same equipment, you name it. You can pay in one place $500, or you can pay in another $5,000. And it's not, you don't have to be a math major to say, as an employer, I'd much rather pay 100% of 500 than 80% of 5,000. And then you get into things like surgeries and hospitalizations, again, not as frequent, but the dollars are bigger. And so, we both know Keith Smith, who was a real pioneer here. And there's still, even with all this gobbling up by these mega health systems, there's still a bunch of docs who are independent and surgery facilities. And it's not an accident. They're still independent. Like, they have fended off a lot of people, private equity, big health systems, whatever. And they're like, hell no. Like, I didn't go into this calling to, basically to answer to Wall Street and Wall Street minded folks. I went into it to be in the caregiving business and healing business. And so we work with them, or there's alternative, kind of collections of contracts that, aren't maybe a big carrier network. And then, of course, drug coverage is really important. And there are great independent PBMs. And, you want to talk about a group that's really gotten the shaft from the current system. Talk to your local independent community pharmacist. I mean, it's unbelievable that it's legal what has happened to them. And so, like in that Ashtabula case, Bryce is the benefit advisor there. He called Maria Fowler, who's the owner of Hoffman's Pharmacy, and said, hey, are you sitting down? I want you to know we're going to change your life here. You are going to be the preferred pharmacy. And she couldn't believe it. Like, she'd never gotten a useful, call from anybody, kind of on the business side. And she talks about just how, and this is true whether it's a doctor or pharmacist, like, there's always going to be challenges and problems coming up. Like, even an independent PBM, there'll be some problems. Like, she could never get anybody on the phone with these mega PBMs or mega carriers. She said, when there's a problem and we're dealing with complex stuff, there's going to be problems. We can get a human on the line and we can solve it in a timely manner. And, one of the pioneers in the direct care back in the day was Ira Health. I actually got my folks into their primary care model. And it's kind of sad that their tagline was restoring humanity to healthcare. It's kind of sad they needed to have that tagline, but it really speaks to what's happened. Is there is a humanity that should be central, right, to this healing art that we have in this incredible science. And so it's bringing the best of the way things were with the modern tools of today. And it's pretty straightforward. And so that's kind of how it works.
That's awesome. So can you tell us more about the role of direct primary care in the success of these community-based health plans?
Yeah, definitely. I'll just give you one example where the second book I wrote was called The Opioid Crisis Wake-Up Call. And it looked at the opioid crisis through the prism of our health plans and all that. And this is an oversimplification, but it's not that far from the truth, that if we treated lower back pain well in this country and didn't have perverse incentives, we would not have had the first 20 years of the opioid crisis. And so there's no evidence that you come in with standard lower back pain, that giving that patient an opioid is the best solution. At best, you're going to mask pain in the short term while the underlying cause gets worse. And if you look at like Rosen, Parallel Path, they never had an anti-opioid program, but what they did was have that direct primary care, advanced primary care model. I said, we've got a PT over here. We got a health coach. They actually go into the workplace, teach people how to, lift mattresses for the people, kind of go upstream. And so that's what you can do when, say, there's some basic things maybe the doc can do, but if they're set up right, if it's not in their clinic, they're very, direct line to, PT. And again, standard lower back pain. There's times when surgery is appropriate, but you have Rosen. When I wrote that book, I went back and said, hey, what's the story with your opioid prescriptions there? And they're like, well, I don't know. We'll look up the data. And they gave me the data on their membership and the number of prescriptions. It was 1/6 of the level of a typical US employer. And they've got physically demanding jobs. And it basically put them in the same levels like France or Italy, where there's really not a catastrophic problem like what we've had. And that's the type of thing where if you have a moment to breathe, you're not, trying to get people on this hamster wheel in and out of the exam room every 7 minutes, but you can actually look at the totality of what they're doing. You're not pressured financially to get them to a, MRI machine down the hall that's going to, charge them an arm and a leg. And then that's going to put you on the fast track to, some other intervention that in the vast majority of the time is not the best method. And so that's the thing where I remember early on talking to Garrison Bliss, I'm like, gosh, how is it that you reduce 50% of surgeries and hospitalizations? He's like, well, we don't ration choices. That's kind of what the other system does. Like, I've been there, 80% of adults have been there. You have that feeling like there's a knife in your back and you're telling me like the only solution to that is some drug or some surgery for standard stuff. I'm like, bring it on, man, make that go away. they say, hey, you can do, here's your options, here's what's going on. And people will generally choose the least invasive thing. If that doesn't work, again, step it up. And the 50% of ER visits aren't an emergency, but we've destroyed primary care in this country, so people can't get in. I mean, like, I was just talking to a guy the other day in our program. It takes 6 months to get into a primary care clinic in greater New York metro area. Like, that ain't primary care. I'm sorry. Like, it's not primary care when it takes that long. You should be able to get in same day, next day. And more than likely, docs tell me across a lot of specialties, but definitely primary care, 2/3, 3/4 of the time, I don't need to see you. I've just, in the old model, I forced you to come in because that's the only way I get paid. Who can blame them? And so when you remove that, maybe shoot a picture of a, rash or something. A lot of that stuff can easily be handled that way. And so it's just common sense things that can get addressed. Look upstream, look at the totality. It is these a lot of these environmental factors, your stress at work, your sleep, your food, right? All these types of things that really the old system is like, God, you don't have time to deal with that. And of course, there's financial incentives for them to keep you as sick as possible for as long as possible. And when you don't have those perverse incentives, then people can actually practice the way they were trained and the way that they wanted to practice when they went into this profession to begin with. And it's a profession that for most people is a calling, but then they've been beaten into submission and to cynicism. And they're like, oh, I'm just going to get mine, or I can't, if I push back, the man upstairs is going to, not the way upstairs in heaven, but like up in the C-suite upstairs is going to whack me. And it's really sad, and we lose every year 10 full graduating medical classes to suicide amongst doctors because it's been made so miserable. And that just is not acceptable by any stretch of the imagination. And there's no reason, if you're in a great setting, that even comes into the mix.
Sure. Well, what you're describing in a lot of ways mirrors my experience as a flight surgeon when I was in the Air Force. I mean, I remember, coming into that role and being told, okay, so you're going to be practicing preventive medicine. And I said, okay, so I'm going to tell people not to run with scissors. Is that what you're telling me? And that's how we're going to prevent stuff? He said, no. You're going to have a far greater impact than you realized. And so my job was to take care of this fighter squadron, all the members of the fighter squadron. So I was their primary care doc. And then when I would start to see patterns of injury, like for instance, you mentioned the back injury. Well, I started seeing a bunch of people who were coming in because of falls and injuries to the back of their head. And I was like, what's going on here? And so I asked them, I said, where do you work? And it turns out they all worked in the same place. They all worked at the wash rack where they wash the jets off before they go fly them. And there's a bunch of reasons for the Air Force to do that. Because, I mean, a dirty jet flies less efficiently. Yeah. And so you pay more money in fuel and it costs more money to maintain them, et cetera. So they said, we'll just wash them. So they had this special car wash, if you will, for the jets. And these guys were slipping and falling and getting hurt in the wash rack. And so the squadron commander said, Doc, go find out what's going on there. And so I did. I went and I looked around, and guess what? I asked them, I said, well, what's the problem? Why is everybody falling? They're like, well, it's because this floor is slippery. I said, well, what's your solution? Like, well, Doc, I mean, nobody'll do it for us. I'm like, just tell me what you need. And they said, well, over at such and such a place, they have this special material they use on the floor that keeps people from slipping and falling. If we had that, then nobody would get hurt. I said, okay, give me the details. I'm going to go talk to the boss about it. I went and I talked to the squadron commander. He said, well, why didn't anybody tell me that? And so they installed this floor. And guess what? All those injuries went away. But that's because I was not incentivized by, I got paid a salary, right? And so when there was a health problem, I figured out, okay, what's causing it? And that wasn't just me. I mean, this is the way it works for a flight surgeon in the Air Force. We're expected to do real preventive medicine. And that is effectively what you're talking about. You reduce costs by fixing the underlying problem.
Yeah. Do you know the origin of direct primary care, how it came into being?
I can only imagine it
It's
has
kind of
something to do with the military.
it doesn't actually, but it when I think about like fighter pilots, right? You know, obviously safety is a big deal, a lot of money on the line, all that. Well, there was a the team doctor for the Seattle Supersonics before Oklahoma, City stole the Sonics from Seattle, and he's like, of course, you're doing everything you can as a team doctor to make sure these highly compensated, high stakes in a different way, people are as healthy as possible. And he's like, there's these other people who are really highly valued, that are called business execs and all that. And so he was business partners with Garrison Bliss. He went up at the high end concierge and served a super expensive thing. Garrison's like, I wanted to serve the regular guy. They don't care about marble lobbies and terry cloth robes when they come in. And I'm doing the math, and back then it was like $40 a month will work 20, 25 years ago. And so it was, I dubbed it concierge medicine for the masses. And so that was kind of the same thing. Like, whether you're, a mechanic in some manufacturing facility, or, literally for a fighter jet, or you're a nurse or you're a teacher, whatever, like everybody should be looked at that way. And they matter and they're essential and all that. And so it's just funny how these things, sometimes the least common thing is common sense, so that's a cool story. I'm definitely going to save the flight surgeon story.
Oh yeah, I mean, I could tell you all kinds of stories like that where the model that you're talking about effectively is applied every day by the Air Force in the flight medicine community. And the reason the Air Force continues to invest in it is because it works. It's doing in the military sector exactly what you're describing in the private sector.
Yep. No, that's great. Looking forward to learn more of those sort of stories.
Sure, I'm happy to share them. So let me ask you this. So, our audience has heard, all of these great things about how these community-based health plans can make a difference, and how we can get back to delivering healthcare the way that it was meant to be delivered. So let's say I'm a primary care doc here in Omaha. How do we do this here?
Yeah, I mean, I think that one is just, talk to your peers. There are other DPC docs. I know Omaha is actually quite strong for that. There's other docs in the direct care movement. I know you're involved in the Free Market Medical Association. Everybody has their own way of coming up to speed, but I think talking to peers, demystify it. How did they go about doing it? And you'll find that, like the Free Market Medical Association, there's these people called benefit advisors or benefit consultants or brokers. Think of them just they're kind of the insurance agent, right? That takes health plans that are traditionally been sold by big carriers, out to they're the actually sales agent for those. But there's just like there's docs who've broken out of the system, there's benefit advisors who've broken out of the system. So talking to them, you might have a situation like the one that Bryce, where like they have a bunch of employee lives that they need to have cared for. And there's some existing, I think it's strata or something like that.
Yes.
That's, in your, so some, maybe you don't want to hang out your own shingle. Maybe you want to work for still independent DPC. So there are organizations like Strata that are around in other areas like Nextera. And so depending on what your thing is, and there's even some organizations that work with larger, really jumbo employers, thousands of lives, that are bigger organizations. So for some people, maybe that's an option, but just demystify it and go to like the events, like FMA has events, Health Rosetta has events. We have our event in late August in Denver. And last year we had over 200 clinicians, mostly physicians, who came. And it's kind of a market making event. You get the true payers of the healthcare system, the employers, and unions. They're really the ones who are writing the checks. I mean, calling a mega carrier who just processes claims a payer is like calling H&R Block or TurboTax or IRS the payer. Like, it's kind of ridiculous that they've managed to pull that off. But the real payers that are holding the purse strings, they come. And so we had over 1,000 folks, back in September, that were clinicians, they were employers, they were unions, they were the benefit advisors, these different solutions that make up the puzzle pieces of a plan, and talk to them, what they're doing, how they've done it. And you might be one who wants to jump into the deep end right away. Other people want to dip a toe in. You can find a model that fits for you, but just get yourself educated. In fact, one of the things it was not something we planned, but it's been interesting, is we have about 250 of these, what we call Health Rosetta advisors. Turns out about a dozen of them are clinicians, mostly physicians, and most of those physicians are DPC, but it's not just DPC, docs. And we haven't officially called it a fellowship, but it's almost like a fellowship where they get this new area. And given that all signs point to the cost of care being the third leading cause of death in America, to be blind to what is actually happening in those health plans. And no offense to the benefit brokers, but it's a little harder to get through medical school than benefits broker school. And so, we have this six, depending on how much time you want to spend, 6 to 10 hour self-guided course. We have these things. We have a bunch of docs, some PTs, and others in. So that's another way you want to dive deeper in. Happy to do that. But it may just be come to the event. There's a lot of sessions. We have a culture that's very different than what you see in a lot of the rest of the healthcare system. We were talking about it before we recorded, about how you spoke to me and Keith and other people, that people have been very open. We have literally open sourced our secret sauce. So what we have done over the last several years, which revolves around a lot of how you go about procuring and contracting, like this really boring stuff, but it's kind of the secret sauce that allows us to do that. We've open sourced it at the event. Like, you can have it whether we're involved or not. We want to change the whole industry. And you find people like that the most accomplished people are the ones who most want to share it, because they're so busy. Like, they're not worried about giving away their secrets. And frankly, if you look at the improved health outcomes, if you could put it into a pill, it would be the blockbuster drug of the century. Like, we know when you get great primary care and you go to the best surgeons and the best facilities, it's not like 0.1% better. It is unbelievably better. Because one of the other leading causes of death is preventable medical mistakes. So guess what? It really matters where you go and what facilities you go to. So that's the type of thing you'll find a group that is whether you're already in practice, you're in fellowship, you're in medical school. At the FMA event, there were a bunch of med students at the event I went to last April. It's really cool. And it's like the scales come off their eyes, like, oh my God, in this world we were indoctrinated, they didn't tell us about this world. It's almost like, I don't know if you remember the movie Narnia. You step into that wardrobe and there's this whole other world. There's this whole other world where doctors are happy, patients are much healthier, employers are much happier. Like, it is dramatically different. It is not slightly better. It's like 10 or 100x better.
Oh, for sure.
And it's proven itself now over a long period of time. It's not some pipe dream.
Oh, absolutely. I mean, I spoke at the last FMMA conference last year, and I'll be speaking at the one upcoming this April. And it was really exciting and encouraging for me to see all those medical students there. I think there was 86 medical students that showed up. And it was amazing. I mean, just their enthusiasm and their excitement, and exactly what you said, that, they're like, why didn't anybody tell us about this before? And I said, well, because a lot of them didn't know. And it's up to us. It's up to us to help them to be exposed to this, to get them to understand. So
yeah, they were really. I had lunch. I just sat at a random table and had lunch, with a few of those medical students, and they were so excited, to learn about this. And and there's certain specialties, including primary care, where everybody's steering them away and going, oh, it's miserable, you won't get paid well. And they're like talking to people like, they seem to be doing great. There's a different story out there than, again, there's a lot of kind of grooming / hazing that happens, going through medical school and residency particularly. And it's nice for them to realize there is some other alternative out there. And some are, more and more are going directly from residency into this.
For sure.
And these organizations, I know you're growing, a lot of these organizations are growing, and their challenge, as a going concern, is letting docs know that this is an option. And then once they do, it's like, oh my gosh, like, yeah, we're not expecting anybody to take a vow of poverty here. They're doing incredible work. Why should we? We usually are increasing their pay because they're getting, usually what happens is the big carriers negotiate with the big health systems and they get whatever they want. And then the table scraps are left over for the smaller folks.
Right.
And we're like, why wouldn't we pay more for, in fact, pay timely and waive all deductibles and cost sharing, all these things that are actually impediments to healing? It's a no-brainer to get rid of those when you're not squandering money on these other things. And we can solve problems for the clinical side because they didn't go to med school to become bill collectors. That's ridiculous. Why wouldn't we pay them right away for doing a great job?
Right, exactly. So as we wrap up here, Dave, I have two final questions for you. The same two questions I ask everybody. First question. As we consider our target audience, again, the medical students, the residents, fellows, people fresh out of training, if there's one takeaway message, one thing you want them to know that you think is the key message, whether it has to do with Health Rosetta or healthcare in general, whatever it might be, what would that one message be?
Healthcare is fixed and you need to join us, right? That's the thing that you hear every day in the headlines. This is a broken system. This is a broken system. That fixed is a true and aspirational statement. That every model that needs to be put in place has been figured out. It's been proven. It's been modestly replicated. Our real challenge is how does that more broadly go out there? And so, we're not under the illusion that it's great for 100% of Americans. But they can be part of that when it's been a pretty rough space. Like we talked about the suicide, we saw the situation with that United Healthcare CEO. People are getting devastated on all sides of the system, and that's a choice these residents and fellows have. They don't have to be party to that. As Keith Smith puts it, he didn't want to be an accomplice to a crime. And it's sort of like a crime, what's happening out there. And so join us, ask all the hard questions, be as skeptical as you can be, but dig in, because there is a whole, in healthcare, medicine in particular, goes through big shifts every 50 to 70 years. We're overdue for that. And it's happening. It just needs to happen faster, and they can be a huge part of that.
Awesome. So last question, how do people find you?
Easy. Just, I'm at Chase Dave on the socials. Like I'm on LinkedIn, just Google Dave Chase. I'm not the Sopranos producer. And just Dave at healthrosetta.org. That's our site, healthrosetta.org. And yeah, I'm pretty reachable. Just message me on LinkedIn or make a connection request. And, if you don't look like you're some salesperson scammer, like, oh, you're a resident, you're a fellow, you're a medical student, you're a doc, and you send a connection request, as long as I'm not backed up, I'm happy to accept it. And you can send messages without that. So very reachable. And, if you wanted to join, us at our event or the program, all that information's on the Health Rosetta site as well.
Awesome. Well, thank you, Dave, again for number one. Thank you for your mentorship. Thank you for all the things that you've done to help me in my practice and in my journey, and all the other doctors out there who have benefited from your experience, your wisdom, and your leadership. So thanks for that. And then thank you for joining us today on the podcast. It was awesome having you on board, and it was exciting. It's always nice for me to get to talk to my heroes. So thank you for that.
Oh yeah, no, that's super kind, and I'm really grateful for what you're doing and you making the move, because I know it is a leap, right? And there's a lot of people who will like, oh, that's not going to work, or, it's crazy or whatever. So make your own decision. You did. It's working. It's working for thousands of docs. So just really grateful for the opportunity today. Thanks again.
Thanks, Dave. And thank you to our listeners for joining us today on the Direct Care Movement podcast. We're excited to have you with us today. We're excited to have Dave Chase with us today. And if you liked what you heard today, then don't keep this a secret. Share it with your friends. Listen to more of these episodes. Get the word out. The future is now, and you can be a part of that. Thank you. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.